Hello, and welcome to episode 11, Fallacy of Generalization, of our Critical Thinking and COVID-19 series. In the last episode, we looked at the inductive generalization and its usefulness in reasoning about certain aspects of the pandemic. As with all reasoning, one must be careful to avoid mistakes in logic, what we philosophers call fallacies. Three fallacies that often arise from efforts to generalize are hasty generalization, appeal to anecdotal evidence, and biased generalization. They sometimes get other names because there's no international body of standards of fallacy naming, but those are pretty common names. We'll look at each of them in the context of the current pandemic. Now first, we have the hasty generalization. And it occurs when a person draws a conclusion about an entire population based on a sample that's not large enough to adequately support the conclusion. To get formal, it's an argument, a bad argument, a fallacy, but fallacies are arguments, they're just bad, that has two premises and of course one conclusion. So premise one is this: sample S, which is too small, is taken from population P. Premise 2, in sample S, X% of the observed A's are B's. Conclusion, therefore, X% of all A's are B's in population P. Being less formal, the idea would be this: pull out a sample, and it's too small from a particular population, and in that sample, there's a certain percentage of one things that are another. For example, a certain percentage of people who have been tested as positive for COVID. And then we conclude that the whole thing, that sample represents the whole population. Now, in the previous episode, we saw a rough guide to sample sizes and looked at the notions of margin of error and confidence level. In this context, the fallacy would occur when the sample was not large enough to warrant a person's confidence in the conclusion. In the case of COVID-19, a generalization that is of great concern is drawing an inference about the lethality of the virus. That is, what percentage of people who get infected actually end up sadly and terribly dying. Now the math for this is easy. It's just simple statistics. The challenge, though, is getting the right information. At this time, there are, unfortunately, large samples of infected people. Thousands of people around the world have been tested. As such, the inferences from these large samples to the lethality of the virus would not be a hasty generalization because there's a big sample. So in this case, the fallacy is not being committed. If we're going from these very large samples to the population as a whole, they're big enough. As we saw in the previous episode, they're large enough to have a small margin of error. But avoiding this particular fallacy doesn't mean the generalization is actually a good one. There are other things, as we'll see, that can go wrong. Now, there are also inferences in the context of COVID-19 that are being drawn from relatively small samples, such as generalizations from various treatments being tested. For example, the samples of people treated with hydroxychloroquine for COVID-19 have been relatively small. So inferences from these samples to the whole population run the risk of committing a hasty generalization. And similarly, we have to apply the same standards to other testing. If the samples are very small, even if the results are good within the sample, we can't be sure that they extend to the whole population because there could be unusual things about that small sample that throw off the reasoning. Now, this is not to deny that even small samples might have some use. In fact, we'll talk more with this in later episodes on causal reasoning. Small samples can be useful. Not the end of the process, but the beginning. Now, speaking of causal reasoning, generalizations about causal factors also involve, obviously enough, causal reasoning, something that adds another level of complexity and induction, and something we'll talk about in the future. As a practical guide, when you hear claims about the pandemic, or anything, based on generalizations, you need to consider whether the conclusion is supported by a sample that is large enough. This does not mean that a sample that is too small means a conclusion must be false, but it does mean the conclusion is not adequately supported by that sample. Now, a popular fallacy that is related to the hasty generalization is what's called the appeal to anecdotal evidence. Sometimes called anecdotal evidence. Again, there's no international bureau of fallacy naming, so you'll see different names. An appeal to anecdotal evidence is committed when the person draws a conclusion about a population based on an anecdote, a story, about one or very few cases. The fallacy is also committed, another version, when someone rejects reasonable statistical data supporting a particular claim in favor of a single example or a small number of examples that go against that statistical data, that claim. As I noted, there's two forms of the fallacy. The first one, form 1, is this. Formally, put, premise 1. Anecdote A is told about member M, or a small number of members of population P. Premise 2, anecdote A says that M is or is not C. Conclusion, therefore, C is or is not true of population P. Put informally, that is this. A particular anecdote is told about a member of a population. This anecdote says that that member has a particular quality or lacks a particular quality, so it's true of the whole population. To use a non-COVID example, someone might say, well, my Aunt Jane smoked lots of cigarettes every day. She lived to be a long time, so smoking, is not really bad for you. So, all this talk of smoking being bad, that's just not true. Now, a second version of this fallacy, in same fallacy, different form, is the form 2, involving rejecting statistical data. Looks like this. Premise 1, there is good statistical evidence for a general claim, claim C. Premise 2, an anecdote A is presented that is an exception to or goes against general claim C. Conclusion, C is false. Put informally, there's good evidence for a claim, statistically speaking. A person presents a story that goes against it, therefore the claim must be false. Using the smoking example, if someone says, there's all this evidence that smoking is bad for you, all these stats, but my Aunt Jane, she smoked, 100 cigars a day, and she lived to be 102. So all that statistical data is BS. And that would be a fallacy. Now, the fallacy, in both forms, is like hasty generalization, in that an inference is drawn from a sample that is too small to adequately support the conclusion. The main difference between the two is that the fallacy of anecdotal evidence involves using a story, an anecdote, as the sample. Now, people often fall victim to this fallacy because anecdotes have more psychological force than statistical data does. Wanting an anecdote to be true also tends to fuel this fallacy. As of this writing, there has been no rigorously proven method of curing COVID-19. Hopefully that will change very soon. But there are various anecdotes about methods purported to work. Even if these anecdotes are not lies or disinformation or misinformation, they don't provide an adequate basis for drawing a conclusion about the general population. This is because the sample is not large enough to warrant the conclusion. As a concrete example, while there are some early positive anecdotes about hydroxychloroquine, wishful thinking and Trump's backing of the drug as a COVID-19 treatment caused some people to accept the anecdotes as adequate evidence. But this was bad reasoning. And this is bad reasoning if it turns out that it, becomes a good treatment, because being correct just by, wishful thinking or guessing, they get it right, but it's not a good method. It would be like, to use an analogy, just guessing on, on a math problem. true. If you guess right, you get it right, but guessing one's way through math is not a good method. You wouldn't want an engineer who designing the plane you're flying on who used guessing. Even if they guessed right one time, you would want them to use actual mathematics. Now, appeals to anecdotal evidence often occur in the context of causal reasoning, such as the case of hydroxychloroquine, and this adds an additional complexities. In a future episode, we will revisit this fallacy in the context of causation in populations. Now, as with any fallacy, it does not follow that the conclusion of an appeal to anecdotal evidence is false. Again, a fallacy doesn't mean false conclusion, it means bad logic. So the error here is accepting the conclusion based on inadequate evidence, not making a false claim. A factual error is just being wrong about the facts. A fallacy is bad logic. And a person could have terrible logic and still get it right in terms of having a true conclusion. So there are important things to distinguish: quality of reasoning and the claims being true or false. As noted earlier, there are very large samples, unfortunately, of infected people that allow generalizations to be drawn without committing the fallacy of hasty generalization. But even large samples can be problematic. This is because samples need to be both large enough and representative enough. This takes us to the fallacy of biased generalization. The problem with the biased sample is that it does not represent the population adequately, and so does not adequately justify drawing the general conclusion. This is because a biased sample can differ in relevant ways from the population that impact the percentages of A's that are B's. And looking at the form of a biased sample, premise 1, sample S, which is too biased, is taken from population P. Premise 2, in sample S, X% of the observed A's are B's. Conclusion, X% of all A's are B's in population P. Put less formally, a sample is pulled from the population. And it could be a very large sample. But the problem is that it's biased in some manner. And so a conclusion is drawn based on this biased sample about the whole population, but it's not going to be good logic because a biased sample, there's an excellent chance that it doesn't represent the population. So drawing an inference from a biased sample, not good logic. Now, in the case of COVID-19, there is a serious problem with biased samples, although the situation is improving. I will focus on inductive generalization about the lethality of the virus as the example. Now, as mentioned many times, the math for calculating lethality is easy. The main challenge is this: sorting out how many people are actually infected. Since the start of the pandemic, the United States has inflicted upon itself a shortage of test kits. Because of this, many of the available tests that are not being given to celebrities and certain politicians have been used on people already showing symptoms, or some people who've been exposed to those known to have been infected. As of this writing, nationwide general testing is not being done. As such, the sample is large, more than 1,000 people, but it is biased because it will contain a disproportionate number of people who are already showing symptoms, and miss many people who are or were infected but asymptomatic. The likely result of this sample is that there'll be in this sample a lethality rate higher than the real lethality rate of the virus. To use a very simplified and fictional example, imagine a population of 1,000 people, and 200 of them are infected with the virus. Of the 200 people infected, imagine that 20 show symptoms, and only they are tested. Then imagine of the 20 people tested, 2 of them die. The sample would show a mortality rate of 10%. But in this hypothetical made-up example, which we know the truth behind it, which you don't know in the real case, But the actual mortality rate would be 2 in 200, which is 1%. This would still be very bad, but not as bad as the biased sample would indicate. This shows one of the many reasons why broad testing is important. It is critical to establishing an accurate lethality rate. If we're only primarily testing people who are showing symptoms, who are already sick, then we're going to get a biased sample, and the lethality rate will generally tend to appear much higher than it is. But we won't know exactly what it is until we get large enough unbiased samples. So an accurate lethality rate, why do we need to know that? Well, it's essential to making rational decisions about our response to the pandemic. Because to be purely coldly pragmatic, as people have pointed out comparing COVID to the flu and car crashes, we do, for various moral, pragmatic reasons, tolerate a certain number of deaths in order to have certain things. For example, we could have 0 automobile fatalities if we didn't, drive cars. But we're willing to tolerate thousands of deaths per year for the use of cars. Similarly, people die, drowning in swimming pools every year. Not many, but people do die, and every death is terrible. It's a loss of a person. We could drop that to 0 by banning all swimming pools. No swimming pools, no swimming pool deaths. But we allow swimming pools, and we allow the deaths because we want swimming pools. And similarly for all other potentially dangerous things. But to make a rational choice, we have to know the lethality level to make that cold and often cruel calculation of how many people are we willing to let die so we can have, cars, so we can have pools, so we can have other things that kill people. In this case, we're making a cold and cruel calculation about how many people are we willing to tolerate dying from COVID to get the economy, back going, to be able to get haircuts again. And, more importantly, being able to, operate really essential services effectively, like food and medical care. But we don't have this information yet. We don't know the true lethality rate. And this ignorance in the United States is largely self-inflicted because of the generally poor response early on and the lack of extensive testing. As a final point, it's important to remember that the lethality of the virus, given what we know currently, does vary between groups in the overall population. We know this based on the death data. So different groups are hit harder or less hard. But to determine the lethality accurately for each group, the samples used in the calculation must be representative of the population. While the overall lethality is important, making rational decisions about the virus also requires knowing the lethality for various groups. For example, the virus seems especially lethal for the elderly, and this should guide rational policies for protecting them. And similarly for other groups. So good decision making requires good information. So we need samples that are large, which we have. We also need samples that are not biased, which currently we generally do not have. As always, stay safe, and I will see you in the future.